I'd like to introduce you to Dr. Amy Liu, who is a internal medicine doc, specifically a hospitalist, who is also board certified in addiction medicine. She received her medical degree from Case Western Reserve University School of Medicine, and then completing her IM residency in addition to her addiction medicine fellowship at the University of Washington. So her interests include the inpatient care and the overlap where substance use disorder can be very challenging for patients, and specifically working with their underserved populations and improving the care transitions for the hospital setting. She works at Providence Regional Medical Center with me. I'm so lucky to have her as a colleague, and she's involved in a lot of committee work that sets our patients up for success in those care transitions. Additionally, she is a fungus fanatic, and I'm not talking about mycology in the clinical sense, but she's an avid forager, in addition to a runner, recently finishing a marathon, which is very inspiring, and a cyclotourist. She also teaches WC residents at the internal medicine residency program at our busy inpatient service. Dr. Luke, please take it away.
Great. Thank you so much. Can you hear me okay? Okay, perfect. Well, I really appreciate the time to come and talk with you guys today about opioid use disorder management in the acute care setting. I don't have any disclosures. So the objectives today, we will review trends in opioid use in the US and Washington state, learn to diagnose opioid use disorder and recognize opioid withdrawal, compare medications for opioid use disorder, MOUD, examine inpatient management strategies for both opioid withdrawal management as well as MOUD initiation. And then finally, we'll go over transition of care considerations for patients started on MOUD during the hospital stay. So first, I wanted to go over some trends in opioid use in the US and Washington state. First off, in Washington state, opioid deaths rose between 2013 through 2019, and then rose much more sharply between 2019 and 2023. This coincides with the increase in fentanyl use at this time. And interestingly, there's been a decrease between 2023 and 2024 in drug-caused death rates, particularly opioid-related deaths. Multiple factors could contribute to the recent drop in overdose deaths, including increased distribution of naloxone, increased access to evidence-based treatment for substance use disorders, shifts in the drug supply, and other public health initiatives in recent years. But it is important for us as clinicians to continue to improve access to care of patients with substance use disorders in order to help continue the trend in decreased overdose deaths, especially in today's volatile political and public health landscape. I wanted to show data as well in Snohomish County where I practice. You can see similar trends to Washington State and overall US trends. Between 2017 and 2024, you can see here the data. The tan line is the total number of opioid overdose deaths. And there's a similar trend to the state trends with a rise since 2017, but a slight decrease between 2023 and 2024. You can also see a significant increase in fentanyl-related deaths since 2019, represented by the blue line. And then a decrease in heroin-related deaths over this time period, represented by the dark colored line. So overall in the US, 64% of US overdose deaths were due to synthetic opioids, primarily fentanyl in 2021. And many counterfeit pills containing fentanyl are pressed to look like prescription opioids like oxycodone, hydrocodone, or alprazolam, or stimulants like amphetamines. So here's a couple photos. You can see on the top right are some photos of real oxycodone, and then below is a counterfeit oxycodone tablet, which actually contains fentanyl. So they look very similar. Colloquially, you may hear these called blues, fentanyl blues. Per 2020 data, 89% of police confiscated fentanyl was in tablet form. And there's been a rise in unintentional overdoses due to drugs like methamphetamine, which have been contaminated by fentanyl. Fentanyl is much more commonly smoked than injected in comparison to heroin, which was previously more prevalent. And because of the unique pharmacokinetic and pharmacodynamic properties of fentanyl, which I'll go over here, this really complicates management of opioid use disorder in the acute care setting. So we know that fentanyl has a higher potency than other full opioid agonists, which leads to higher opioid tolerance and high lipophilicity, which means that it is slower to clear from the system and can lead to prolonged, severe, and unpredictable withdrawal symptoms. The increased use of fentanyl in our patient population necessitates changes in opioid use disorder management in the inpatient setting, specifically when we're starting MOUD treatment. There is a risk of precipitated withdrawal with buprenorphine, and also with methadone initiation, there is a risk of opioid withdrawal with slower titration of methadone. Fentanyl, as we know, is highly addictive, but also dangerous in terms of overdose risk because of those unique properties. So, as internists who practice in the inpatient setting, why is it important to address substance use disorders? So, first off, SUDs have a relatively high prevalence in the inpatient setting. Um, According to one study, one US retrospective study in 2021, 1 of 11 patients seen in the ER and 1 of 9 patients who were hospitalized had an SUD diagnosis. We also know that treating substance withdrawal and SUDs improves outcomes for our hospitalized patients in terms of decreased risk of patient-directed discharges, reduced overdoses and readmissions, and increased linkage to outpatient SUD treatment. Clinicians who take a non-judgmental and informed approach to SUD management can build trust with patients with SUDs and increase their engagement in medical care. And overall, because patients with SUDs often have many barriers to accessing medical care, the hospitalized setting is a really key opportunity to provide them with care, treatment, and resources for their SUD. So next, I wanted to go over the diagnosis of opioid use disorder and opioid withdrawal. So OUD is a type of substance use disorder, which I'll define in a later slide. But I first just wanted to note that SED is a DSM-5 recognized diagnosis and is the correct terminology to describe a substance, quote unquote, addiction. Unlike substance abuse and substance dependence, which were terminologies defined in the DSM-4, but not in the current DSM-5. So SUD is defined as persistent substance use despite negative consequences. And why does it matter in terms of terminology? The term abuse, substance abuse, perpetuates stigmatizing attitudes, even in highly trained or medical or mental health professionals. And then substance dependence is really an inaccurate term to describe substance use disorder, since it describes a physiological state, but is not equivalent to all the features of substance use disorder. For example, someone who's prescribed opioids long term, for example, for chronic pain or cancer related pain, can develop a dependence on opioids, meaning that if they stop using the opioids abruptly, they will experience withdrawal. But this is not equivalent to an opioid use disorder in the absence of other features of SUDs. So, similarly to SUD diagnosis in general, opioid use disorder has 11 criteria as per the DSM-5, and you need at least 2 to qualify as an opioid use disorder. I won't read all of these aloud to you, but know that these generally describe continued use of opioids despite adverse consequences of use. And note that there are 2 criteria at the end, tolerance and withdrawal, that describe physiologic adaptations to opioids. It is important, specifically in opioid use disorder, to note that these criteria in isolation are not sufficient for diagnosis of opioid use disorder in people who are taking opioids under appropriate medical supervision. So if someone is on opioids chronically that are prescribed and they do develop tolerance and withdrawal symptoms, which can be expected, then these criteria alone don't count towards a diagnosis of opioid use disorder. The person would need to have at least 2 other features of opioid use disorder to be diagnosed as OUD. So this slide highlights the signs and symptoms of opioid withdrawal. Note that some of these subjective and objective findings overlap with other substance withdrawal symptoms, such as alcohol withdrawal. As you can see on the right side here, there are varying times of onset of withdrawal symptoms depending on the type of opioid use. So for heroin, oxycodone, or other short-acting opioids, we would expect opioid withdrawal to onset between 8 and 12 hours or so. For long-acting opioids such as methadone or buprenorphine, the time of onset of withdrawal could be more like 24 to 72 hours. And then fentanyl notably has a variable time of onset for withdrawal, anywhere between 8 to 24 hours, but can often develop prolonged withdrawal over several days. So the clinical opiate withdrawal scale, or COWS score, is a useful tool analogous to the CWA score in alcohol withdrawal to quantify the severity of a patient's opioid withdrawal symptoms. As you can see, there are both objective and subjective criteria in this scale, and there can be some inter-observer variation similar to the CWA scale. And then some features can be nonspecific and could be related to other non-opioid withdrawal conditions like alcohol withdrawal. But overall, this can be really useful for determining a patient's state of withdrawal or severity of withdrawal. This is particularly useful when starting medications for opioid use disorder, for example, for buprenorphine starts. At my institution, nurses are trained in measuring the COWS score and documenting this. And so your institution may vary in this, but this can be a really helpful tool in the inpatient setting. So we'll compare medications next for opioid use disorder, also known as MOUD. So the purpose of MOUD is to reduce or stop opioid use and mitigate the negative effects of opioid use by controlling opioid withdrawal symptoms. And so this is more specific for MOUDs that are opioid agonists, so methadone and buprenorphine, also reducing opioid cravings, blocking reinforcement of ongoing opioid use, and promoting engagement in recovery-oriented activities. So it's important to note that MOUD is standard of care in opioid use disorder and should be offered during hospitalization. So next we'll go over the 3 FDA-approved medications in the US for opioid use disorder: methadone, buprenorphine, and naltrexone. They differ by their intrinsic activity at the mu opioid receptor. So on the top here is methadone, which is a full opioid agonist, meaning at higher doses, the methadone does maximally activate the opioid receptors like other opioid agonists. Then next, the middle line is buprenorphine, which is a partial opioid agonist, meaning that it has a ceiling effect, so it does not activate opioid receptors beyond a certain point and not 100%. The final line here is naltrexone, which is an opioid antagonist or opioid blocker. It binds the opioid receptor but does not activate it, and it blocks a opioid agonist from binding and activating the receptor. So the graphic here illustrates the opioid receptor activity in the brain as someone uses opioids acutely, where each time they use the opioid, as you see in this graph, they get the desired effect, such as euphoria or pain relief. But as the person develops tolerance and physical dependence, they require higher and higher doses to get the desired effect. And if they're not using the opioid, then they can develop withdrawal symptoms. So that's the physiologic adaptation with chronic use of opioids. But by starting long-acting opioid agonist MOUD therapy, like buprenorphine or methadone, the idea is that the person's opioid receptors can be stabilized in the normal range, which will reduce their cravings for opioid use, eliminate withdrawal symptoms, and support their engagement and recovery activities. So this is kind of an answer to the common question that I get, which is when you're prescribing methadone or buprenorphine, aren't you just replacing one drug for another? And so this is a common misconception. The intention of opioid agonist therapy is really to stabilize a patient's opioid receptor activity to achieve sobriety from non-prescribed opioids and support their recovery. And on therapeutic doses of methadone or bup, patients should not be getting high or having euphoric effects. And on the flip side, they should not be having any withdrawal symptoms or cravings. There is evidence to show that methadone and buprenorphine are associated with reduced mortality. However, naltrexone has less clear evidence of benefit. So this slide here shows some results from a study in 2018. It was a retrospective cohort study from Boston that looked at 17,000 opioid overdose survivors, and they were followed for 12 months after the opioid overdose event. Uh, of those patients who received MOUD, there was a significant reduction in all-cause mortality with methadone and buprenorphine, but not naltrexone. And so the adjusted hazard ratio was 0.37 for methadone and 0.35 for buprenorphine, and this was found to be significant, but a non-significant adjusted hazard ratio for naltrexone. I didn't picture this here, but there was a Cochrane review from 2025 that showed that injectable naltrexone can reduce illicit opioid use and reduce serious adverse events, but was problematic in terms of lower retention and treatment. So overall, I would say that methadone and buprenorphine as MOUD do have significant evidence for improved mortality for opioid use disorder. So next we'll talk about practical tips for management of opioid withdrawal and starting MOUD in the inpatient setting. So first off, regardless of a patient's desire to start on MOUD, treating opioid withdrawal appropriately can reduce complications in the hospital, including improving withdrawal symptoms, increasing patient engagement in care, reducing risk of patient-directed discharge, and reducing risk of after-hospital overdose. Even if a patient does not plan to continue these medications as for opioid use disorder after discharge, they should still be offered. So in terms of treating opioid withdrawal with methadone or buprenorphine, I have some suggestions here for dosing. So for methadone, typically we would recommend starting 20 to 30 milligrams to start, then giving 5 to 10 milligrams 4 to 6 hours later if there are still ongoing withdrawal symptoms, up to a maximum of 40 to 60 milligrams on day 1. With buprenorphine, we do want to wait until the COW score is at least 8 to reduce the risk of precipitated withdrawal. First, we give a 2 to 4 milligram dose of sublingual buprenorphine, and then you can give an additional 4 milligrams every 1 to 2 hours after that if there are still ongoing withdrawal symptoms, typically up to a maximum of 16 to 32 milligrams of buprenorphine in the first day. We do tailor the starting dose to the patient's baseline opioid tolerance, since higher doses of opioid agonists may be necessary to manage withdrawal symptoms if the patient has a higher opioid tolerance. And then, of course, we want to make sure to balance this with the risk of respiratory depression or sedation, depending on the clinical situation. Here are some non-opioid options for treatment of opioid withdrawal that can be utilized. I find these to be especially helpful as adjuncts to starting patients on MOUD, buprenorphine, for example. But I did want to reiterate that offering MOUD, including buprenorphine or methadone, is standard of care in OUD and should be offered during hospitalization. And these non-opioid symptomatic medications in isolation are not the preferred approach for treatment of opioid withdrawal. Of this list, I find clonidine, gabapentin, and hydroxyzine to be particularly helpful for management of opioid withdrawal symptoms if there are no contraindications for their use. But we do need to keep in mind potential adverse effects like hypotension, sedation, and sedation, for example, when using these medications. So moving on to inpatient initiation of MOUD, as I mentioned before, the inpatient setting is a really great opportunity to get patients started on MOUD and link them to care after hospitalization. Of course, if someone is already on MOUD, we generally recommend continuing this during the admission and adjusting the dose as needed. But if they are not on MOUD, definitely should offer during the hospitalization, keeping in mind patients' preferences. So motivational interviewing can be really important to explore a patient's readiness to change and their interest in MOUD and other resources for SUD treatment as an important first step. Providing education on all the options is really important in the hospital setting, and Of course, we do need to keep in mind other clinical factors that could play into our choice of MOUD, including co-recurring pain or other substance use disorders, QTC prolongation, sedation, or respiratory depression risks. It's also important to think ahead to the access the patient will have after the hospitalization for continuing their OUD treatment. So all these things should be considered when you're making a choice on MOUD with your patient. So as I mentioned before, naltrexone extended release does have some decreased or some relatively lower evidence for benefit in OUD treatment, but according to some meta-analyses, but some patients do prefer this. For example, if they want to be opioid free, or if they have some other contraindication or barrier to getting opioid agonist therapy. It also can be used for co-occurring opioid use disorder and alcohol use disorder. Um, and, and so in the hospital setting, due to the risk of precipitated opioid withdrawal, we do need to be cautious about when to start naltrexone after the last use of opioids. So generally, we recommend starting naltrexone no sooner than 6 days after the last dose of any short-acting opioids. And then for long-acting opioids, such as methadone or buprenorphine, we do want to wait at least 7 to 10 days before starting naltrexone. One approach to starting naltrexone is to give a test dose of naloxone beforehand, just to test for any precipitated withdrawal before giving the full injection. So one protocol for this would be to give a dose of naloxone 0.2 milligrams IV, waiting 30 seconds. And if the patient tolerates this, then giving another 0.6 milligrams of IV naloxone. If there are no withdrawal symptoms after 20 minutes, then you can give the dose of naltrexone, 380 milligrams IM. Or you can give a dose of 0.8 milligrams subcutaneous naloxone, wait 20 minutes, and then if no withdrawal, then you can give the naltrexone dose. Naltrexone for MOUD is given once a month as a 380 milligram IM injection in the gluteal muscle. And so in follow-up after the hospitalization, the patient should make sure to have a follow-up appointment with a prescribing clinician outpatient for the next dose. So next I wanted to discuss how to start methadone in the inpatient setting for opioid use disorder. There aren't any society guidelines currently for inpatient methadone titration. And so titration strategies are usually based on expert opinion, observational studies, and extrapolation from the outpatient setting. And so we'll consider both traditional and rapid initiation strategies here, which I'll describe. Overall, before starting methadone, there are some clinical considerations, including the need to check the baseline EKG, because a QTC of more than 500 is a relative contraindication for methadone. So starting methadone is often institutionally dependent and based on clinician experience, because like I said, there aren't really any clear guidelines for the inpatient setting for titration. A lot of what we know and what we recommend for methadone starts is based on opioid treatment program or OTP guidelines. So traditionally, this is how methadone was started. Day one, we would start with an initial dose of 10 to 30 milligrams, then give 5 milligrams every 2 to 4 hours as needed after that for a max additional doses of two. The maximum day one dose is 40 milligrams typically with this approach. And then after the first day, we increase the methadone dosing by no more than 5 to 10 milligrams every 3 to 5 days. The idea here is that methadone is a long-acting opioid agonist, and so we need to uptitrate slowly to prevent dose stacking and adverse events from raising the dose too quickly. So, and then we adjust the dose on subsequent days based on opioid withdrawal, craving, or adverse effects like sedation. So prior to the rise of fentanyl use in the population, this traditional approach was used more commonly in the acute care setting with better success. But with fentanyl being used more commonly these days and with increased opioid tolerance levels, this approach to starting methadone in the inpatient setting can often be insufficient for fully managing opioid withdrawal symptoms. So next I wanted to talk about rapid starts for methadone. So nowadays, providers who treat OUD often note that patients stabilize at higher doses of methadone than previously. So we've seen some better success with titrating methadone more rapidly. This is an example approach here. I just want to note that this is based on expert opinion with limited observational studies as evidence, at least currently. So here in this protocol here, you can see that on day one, the initial dose is similar to the previous protocol, generally no more than 40 milligrams to start on day one. And then on day two, we do increase from the first day's total daily dose up to a maximum of 50 milligrams based on a patient's opioid withdrawal symptoms as well as cravings. Then day three, we take the second day's total daily dose, and we can increase that by another 5 to 10 milligrams up to a total daily dose of 60 milligrams on day three. After we get to the 60 milligram total daily dose, the dose can be further up titrated every 3 to 4 days as needed by 5 to 10 milligrams in order to continue to address withdrawal symptoms or cravings. So it's important to note that some clinicians may titrate up even more quickly than this, but this is just an example approach. So to continue a patient's outpatient methadone, if they were already on this for opioid use disorder prior to admission, it is important to confirm with the opioid treatment program that they go to. So what I do is I ask the patient where they go for their methadone dosing. I look up the clinic's phone number and call to verify their dose. Of note, OTPs often open up early in the morning and they close relatively early. So it is important to call as soon as possible in the morning. Depending on your institution, your pharmacist may be able to assist with verification. If you are unable to confirm with the OTP on admission, for example, if the patient is admitted overnight, then you can give an initial dose of 30 to 40 milligrams of methadone and then verify the actual dose in the morning. So if the OTP says that the patient has missed 3 to 4 days of methadone dosing, then typically I recommend or I consider decreasing by 50% initially. And then if the patient has missed more than 4 days of methadone at the opioid treatment program, then it is recommended to start over with methadone initiation, for example, 20 to 40 milligrams to start. As with any MOAD initiation, it is important to check the PDMP to see if a patient has had any opioids dispensed to them previously or any other scheduled medications. Methadone of note for opioid use disorder is not reported on the PDMP, but it is reported for pain as if it's prescribed for pain as an indication. But buprenorphine is reported on the PDMP. So some additional thoughts on methadone starts. We could consider split dosing methadone for analgesic effect if there is co-occurring acute pain. So twice daily or 3 times daily dosing can be more effective for analgesic effect than once daily dosing for methadone. But then of note, if you are going to continue the methadone as MOUD after discharge, then the dose should be consolidated to once daily dosing at least a few days before discharge, just to make sure that the patient tolerates it. We can add short-acting opioids for acute pain up on top of the baseline methadone, if indicated, while keeping in mind the patient's baseline opioid tolerance and recognizing that higher doses of opioids may be needed for acute pain management. And then finally, we do want to look out for side effects, as with all opioid agonists, and any drug-drug interactions between methadone and other medications the patient may be taking. So next up, we'll talk about buprenorphine, which can be more challenging to start as MOD in the era of fentanyl. So as a reminder, buprenorphine is a partial agonist at the mu-opioid receptor. It does have a ceiling effect on respiratory depression, which carries a lower risk of overdose compared to methadone or other opioid agonists. It does have a high affinity for mu-opioid receptors, which means that it displaces other opioids, and I'll describe how that leads to precipitated withdrawal in a later slide. And then it has a poor oral bioavailability. So it's given sublingually or subcutaneously for opioid use disorder. And then for pain indications, it can be given transdermally or buccally. In terms of the pharmacokinetics of buprenorphine, when given sublingually, it has a peak level between 3 to 6 hours. It has a relatively long half-life of over 24 hours. And the typical maintenance dose for opioid use disorder is generally between 16 to 24 milligrams daily, with a maximum of 32 milligrams daily. There are subcutaneous weekly or monthly injection formulations of buprenorphine. So there is one formulation that's weekly. It's 32 milligrams per week for this option, or 128 milligrams for monthly. There is another formulation that is 300 milligrams monthly dose, or 100 milligram monthly doses. So it just kind of depends on the brand. Buprenorphine, unlike methadone, does not prolong the QTC, which is important to keep in mind. And here's a list of the various formulations of buprenorphine. So as you can see, there are sublingual and subcutaneous forms, which are indicated for opioid use disorder. But then there are buccal and transdermal formulations as well for chronic pain, but they are not FDA approved for opioid use disorder. Um, so there are so for opioid use disorder, the sublingual formulations include naloxone in the formulation. So you'll see buprenorphine naloxone as a combination. The intention of the naloxone being included in this formulation is meant to deter from misuse, because when taken sublingually as prescribed, the naloxone is not active. But if the medication is dissolved or injected, the naloxone would be active at that point. So therefore, naloxone's inclusion in this formulation is meant to deter IM or IV use of the drug. So you might hear patients say that they haven't done well with buprenorphine in the past because it made them sick. So why is this? This is a graphic that shows the effect of the full opioid agonist in comparison to buprenorphine, a partial opioid agonist, on an opioid-dependent patient. So in the first graphic here, you can see that when a patient is using opioids chronically, their mu opioid receptors are downregulated and desensitized at baseline. So if they don't have any opioids in their system, then they can develop opioid withdrawal symptoms. Then, as you see in the second picture here, if a full opioid agonist is introduced into the system, the opioid agonist binds to the opioid receptors and eliminates withdrawal symptoms. But then if we give buprenorphine while the full agonist is still in the system, the buprenorphine actually displaces the full opioid agonist because of buprenorphine's higher affinity for the opioid receptor. Because the buprenorphine is only a partial opioid agonist and not a full opioid agonist, opioid activation becomes relatively lower. And so this can lead to opioid precipitated withdrawal. So keeping in mind the unique properties of buprenorphine, there are several approaches to starting the buprenorphine, and so we will talk about each one of them and the pros and cons of each approach. So there's the withdrawal start, also known as the traditional start, the rapid start, also known as high dose, and the overlapping or low dose start. And then we'll talk about practical considerations for each approach. So in terms of the standard initiation approach for buprenorphine, this used to be more straightforward in the era of heroin use, but with fentanyl use being more prevalent, there is an increased risk of precipitated withdrawal even with the start. So generally with this traditional approach, we would stop opioids and wait until the CAL score is at least 8. And then at that point, on the first day of starting buprenorphine, we would give an initial dose of 2 to 4 milligrams sublingually, and then additional doses of 2 to 4 milligrams every 2 to 4 hours as needed until the opioid withdrawal resolves. The usual total daily dose for day 1 is 8 to 16 milligrams buprenorphine total with this approach. And then on subsequent days, we would increase from the prior total daily dose by 4 to 8 milligrams daily, with a typical maintenance range being between 8 and 24 milligrams of buprenorphine daily, up to a maximum of 32 milligrams. So the major advantage of this protocol is that it's fairly straightforward and easy to understand. Basically, you just tell the patient to wait as long as possible until they're in pretty significant opioid withdrawal, and then start the buprenorphine. But the downsides to this approach I'll discuss in the next slide. So the issue with the traditional approach to buprenorphine starts is that the patient does need a detox from the opioids first, which can be uncomfortable. There is a risk of return to use when the opioid agonist is stopped. We can run the risk of precipitating withdrawal if the buprenorphine is given too soon after stopping the opioid agonist, especially with fentanyl. And with this approach, it's a relatively slow up titration of buprenorphine. And so the patient may develop uncomfortable withdrawal symptoms during this up titration, and that risks decreased tolerance of the approach and also increased risk of return to use. So the second approach I wanted to discuss is the high dose bup initiation, also known as the rapid buprenorphine start. And the idea here is to minimize the time period where someone might experience precipitated withdrawal. So in my anecdotal experience, this approach can work for a patient who's really motivated and prepared to take on a relatively short period of opioid withdrawal symptoms over the course of a few hours to a day. The rapid approach is similar to the withdrawal start, but we start with a higher dose of buprenorphine on day one, so at least 16 to 32 milligrams generally. And we do still try to wait until at least the COW score is 8 or greater. The advantages to the starting approach is that it's a relatively less complex protocol than the overlapping or withdrawal start, which I'm going to describe later. And it could be more effective in achieving a therapeutic dose while minimizing the withdrawal period. Some of the things to think about with this approach is that there is pretty limited evidence for this approach in the literature, at least for now. It is limited to retrospective studies from the ER setting. But in these studies, we actually have seen surprisingly few cases of precipitated withdrawal, even with fentanyl use, and it is relatively well tolerated, at least in these studies. So I think there is some promise with this approach, but definitely needs careful counseling with your patients before starting this approach. So finally, I wanted to discuss the overlapping approach to starting buprenorphine, also known as the low dose buprenorphine start, which I use in my practice much more commonly in the hospitalized setting than the other approaches. So the general idea here is that we overlap full agonists with a gradual up titration of the buprenorphine. The goal here is to minimize precipitated withdrawal while getting the buprenorphine to a therapeutic dose. The advantage of this approach is that a patient who may be fearful or may have had negative past experiences with precipitated withdrawal may find this approach to be more acceptable because we do minimize the withdrawal symptoms. And if someone is dealing with acute pain in addition to opioid withdrawal, we can still start this approach while the patient is receiving full opioid agonists. Some of the downsides to this approach, it is a more complex protocol to follow. So doing this outpatient can be challenging for many patients, which is another reason why hospitalization is a good opportunity to start buprenorphine by this approach. Also, it does take a few days to get up to a therapeutic dose of buprenorphine by this route. So just keeping that in mind in terms of how long you would expect a patient to stay hospitalized. So going back to the graphic from earlier, so starting low doses of buprenorphine by this approach can help minimize withdrawal symptoms. So in the first picture here, small amounts of buprenorphine are given while the patient has full opioid agonists in their system. As the buprenorphine is given at low doses, it minimally displaces the full agonist at the mu opioid receptor. And as we give increasing doses of buprenorphine over the course of a few days, all of the opioid receptors should eventually be filled with buprenorphine. Once buprenorphine is at a therapeutic dose, then we can stop the full agonist and the patient can continue with buprenorphine alone. So this allows for maintenance of the opioid tone of the opioid receptors without any significant opioid withdrawal. So here's an example of the overlapping protocol done over the course of 7 days. On the right-hand column here, you can see that we continue a full agonist. In this case, it's methadone, 40 milligrams daily. And then in the first column here, we start with a very low dose of buprenorphine on day 1, and then increase the dose daily until we reach a therapeutic buprenorphine dose by day 6. So in this protocol here, you can see by day 6, we reach 4 milligrams BID dosing of the buprenorphine, which is 8 milligrams total in that day. At that point, we can stop the methadone since the buprenorphine is at therapeutic dose, and then we can titrate the buprenorphine to effect on subsequent days. Note that because we're using buprenorphine sublingual films or tablets in this approach, they will need to be cut to get to the lower doses of buprenorphine on the initial days, which is what we're describing here in the second column. But alternatively, formulations like buccal buprenorphine can be used in the inpatient setting, which are in the microgram range. So they're smaller doses than the films or tablets. This is another example of an overlapping start protocol for buprenorphine, this time with usage of hydromorphone as a full opioid agonist. You can see that in the third column here. And in this case, we were using the hydromorphone as a treatment for acute pain as well. And then in the second column, you can see here the buprenorphine dosing is being up titrated to a final daily dose of 32 milligrams by day 4. This is clearly a faster protocol than the previous protocol that I was showing, and also with a different full opioid agonist. There is still risk of precipitated withdrawal with this approach, but the key thing here is that you can always slow down the rate of up titration of the buprenorphine, or you can increase the full agonist dose temporarily while you're up titrating buprenorphine in order to treat withdrawal symptoms as they arise. So next I wanted to discuss what to do if someone is already on buprenorphine prior to admission. So generally, we do not recommend stopping the buprenorphine in the hospital. If the patient needs to get full opioid agonist for pain, they can still get these while also continuing their buprenorphine. Be aware of the different formulations of buprenorphine for pain or opioid use disorder, and try to keep them on the same equivalent dosing in the hospital. And generally, we do not recommend stopping buprenorphine preoperatively. If buprenorphine is stopped for any reason and the patient is started on full agonist, then we have a few options of what to do next. So if it's only been 1 day of missed buprenorphine, then we can generally resume the home buprenorphine dose as soon as possible. But if it's been 2 or more days off buprenorphine, then we should likely restart the buprenorphine via the overlapping protocol. And then just as a reminder, it is always important to check the PDMP to verify that the patient has been filling their buprenorphine recently, or to determine whether they've had any other opioids filled recently. So just to summarize again, the evidence for buprenorphine starts. Most studies are observational case series with heterogeneous populations, methods, and reported outcomes, but there is some evidence for efficacy for the overlapping or low dose start for buprenorphine. Most data for overlapping starts is currently from the inpatient setting with some limited generalizability to the outpatient setting. And then there is limited data on the high dose or rapid transition from opioid agonists to buprenorphine, but anecdotally, there may be some benefit to the strategy in selected patients. So when I describe buprenorphine starts to patients, I generally try to kind of use a metaphor, and the metaphor that I like to use is a cold water analogy. So some people may, when getting into cold water, some people may prefer to jump right in. They are willing to withstand a little bit of discomfort in order to get acclimated to the water more quickly, whereas some people may prefer to ease slowly into the water, get used to the temperature over a longer period of time in order to minimize discomfort, but this does take longer. So similarly, some patients who are more tolerant of opioid withdrawal symptoms may be able to get through a rapid or withdrawal initiation approach for buprenorphine, whereas some patients may want to minimize opioid withdrawal symptoms, in which case the overlapping approach might be more helpful. So here's just a summary slide again of the MOUD options available for patients. I think this presentation will be shared later for your reference, so I'll just have that here. And then finally, I wanted to make mention of, briefly mention some tips with management of acute pain and opioid use disorder. So with all acute pain, we definitely want to utilize and maximize non-opioid analgesics. But if opioids are indicated for acute pain, it is important to give them if indicated. We know that giving opioids will not worsen someone's opioid use disorder, and withholding opioids will not improve someone's opioid use disorder. So give opioids if indicated in acute pain. Keep in mind, though, that patients will have likely have higher opioid tolerance if they have a history of opioid use disorder, and therefore higher opioid doses may be needed for pain control. It is important to note that it is okay to give methadone in addition to other short-acting opioids if they are indicated, and it is okay to start low-dose buprenorphine protocol while a patient is still on opioid agonists. So we're going to go over a case example now with a poll for your answers to this question, but I actually don't know if I can see anyone's results. So I might need to, sorry, I'm actually not sure how to take a look at what's going on here, but anyway, so I'll just go over the slide and the case example, and people can um, input their responses. So we have
Looks
a
like
30-year-old
we
man.
it
Uh-huh.
looks like we lost your slide, by the way.
Oh, okay. Sorry
Maybe you
about that.
minimized it or moved it to a different screen.
Yes. Is it
There it
back?
is. It's back.
Okay, perfect. Thank you. Okay, so here we have a 30-year-old man who is admitted for left leg cellulitis with abscess. He started on IV vancomycin and undergoes IND in the OR. He reports a 10-year history of opioid use, including smoking 1 gram of fentanyl daily in the past 3 years. He tried methadone for opioid use disorder 2 years ago, but stopped after 4 months. His last use of fentanyl was 48 hours ago, and he is reporting sweating, nausea, anxiety, and GI upset. And he also has severe pain of the leg at the IND site. So, how would you manage his pain and opioid withdrawal? So, we have five different choices here. So, A is methadone 10 milligrams TID, B, loperamide, ibuprofen, and clonidine. C, oxycodone 5 milligrams every 8 hours. D, hydromorphone PCA. Or E, buprenorphine 8 milligrams twice a day. So I'll wait like, let's say 20 seconds and see what people say. I don't know if I'm going to be able to see the results.
I'll read them out to you. Amy, how does that sound? It looks like we
Sure.
have two for A, one for answer B, and two for D. So pretty good spread between A, B, and D.
Okay, great. So I would say that the answer to this is not straightforward. There could be a combination of answers here, which I think maybe why people chose different options here. But for this patient with opioid use disorder and opioid withdrawal and acute pain after surgery, there are several possible approaches that we could take here. First off, we just need to keep in mind that it is standard of care to offer MOUD for patients. So either A or E could be considered. But the problem with E is that it does carry a risk of precipitated withdrawal. But depending on the CAL scores, this could be reasonable. A reason not to choose E would be also if they're already on full opioid agonists for pain. So a low dose beep start could work in this case for OUD. So I think A would be reasonable in terms of MOUD options. Split dosing would make sense also to start both for acute pain management as well as for OUD and opioid withdrawal. I think D is also reasonable, but I would not recommend this in isolation unless the patient strongly prefers this after education. Um, C, I think, would not be ideal because oxycodone at the doses here would likely not be sufficient for pain control, given that this patient likely has high opioid tolerance. And then D, I think, is reasonable. You could consider this for acute pain in addition to discussing MOUD and maximizing non-opioid pain modalities. So I think a combination of these approaches may be reasonable. So next we'll review considerations for patients with OUD who are transitioning out of the hospitalized setting. So, obviously, if you have an addiction consult service available at your institution, consulting them early and getting their assistance with transition of care can be really important and really helpful for patients. Um, so for methadone specifically, when patients are discharged on methadone, it'll be important to schedule them with an OTP, opioid treatment program intake appointment prior to discharge to ensure that they can continue with their MOUD after discharge. So ideally, if the patient is going to their follow-up appointment the day after discharge, then you can give the methadone dosing the morning of discharge. But if for whatever reason the methadone appointment is unable to be arranged for the next day, up to 3 days of methadone can be dispensed from the inpatient pharmacy, but not prescribed while coordinating with the opioid treatment program. So this is a really important thing to note, and it is a little bit institutionally dependent whether your inpatient pharmacy is able to accommodate for this. But there is an exception to federal regulations known as the 72-hour methadone rule that allows for up to 3 days worth of methadone to be dispensed um, to a non-hospitalized patient while referral to treatment is being arranged. But outside of this window, it is not legal to prescribe methadone for opioid use disorder outside of an opioid treatment program. And then another thing to note in terms of transitions of care for methadone is that it may be a challenge to continue with methadone after discharge if a patient is going to skilled nursing facilities, as it can only be dispensed by an opioid treatment program. So some skilled nursing facilities may have a relationship with an opioid treatment program and allow for this option, but it is important to determine this ahead of time. In terms of MOUD with buprenorphine, um, it is important to ensure follow-up as well for buprenorphine, but the follow-up date can be somewhat more flexible than with methadone, and it doesn't have to be with an opioid treatment program. So buprenorphine can be prescribed for MOUD with a PCP, with an opioid treatment program, or another SUD treatment clinic with a prescribing MOUD prescriber. Ideally, we would arrange this follow-up appointment within 1 to 2 weeks after discharge, and I always prescribe enough buprenorphine on discharge to get to the follow-up appointment. If a patient is discharging to a skilled nursing facility, this is less of a barrier in comparison to methadone, but you should still confirm with the skilled nursing facility that they will agree to continue to prescribe the buprenorphine naloxone for opioid use disorder after discharge. And then here's an overview of the different MOUD options from a logistical perspective. So as you can see here, naltrexone and buprenorphine can be administered outside of an opioid treatment program, but methadone, again, is restricted to OTPs only. Any prescribing clinician can prescribe naltrexone, and any clinician with a DEA registration can prescribe buprenorphine. The pharmacy type is also restricted to OTP pharmacies for methadone dispensing, but any non-OTP pharmacy is okay for prescribing naltrexone or buprenorphine. And then finally, a quick point on harm reduction measures in the hospital to keep in mind. Always prescribe naloxone for patients with opioid use disorder on discharge or those with opioid use, and give education on overdose prevention. Also, it's important to be familiar with the community resources in your area for patients with substance use disorders, including syringe services programs, drug testing supply programs, other SED treatment options. And then counseling on safer use practices is also important. It can be really helpful if you have a peer educator or an SED consult service available to help with counseling. And then finally, screening patients with substance use disorders for infections like HIV, Hep B, Hep C, TB, and STIs for this really vulnerable patient population. Here's just a picture of naloxone nasal sprays and injection. And then the Washington Recovery Helpline can be helpful for looking for SED resources for patients in our state. So So, you know, as hospitalists, we really have a valuable opportunity for managing SUDs in the hospital setting and caring for these really vulnerable patients. So I really appreciate your attention today. These are some providers and mentors who have been really helpful for providing feedback for me. Um, and I'm happy to take any questions.
Great. Thank you so much, Dr. Liu. I have a few questions here, starting with one from our audience member, Gabe. With these ceiling effects of methadone and buprenorphine, and Dr. Liu, I'll let you clarify if there are ceiling effects for methadone. Why do we sometimes see patients needing much higher doses? Shouldn't we already be sort of tapped out at that 40% activation rate? Why do some people need a lot more? What is the benefit from that?
Yeah, I guess to clarify, buprenorphine doesn't have that ceiling effect since it is a partial opioid agonist. Methadone, because it is a full agonist, doesn't really have that sort of ceiling effect that I think you're describing. Um, so I think that the higher doses needed for buprenorphine, even with that ceiling effect, I think probably just relate to the fact that people are more opioid tolerant. I think even though there is that ceiling effect, I think you achieve that true ceiling effect at the higher doses of buprenorphine. So anecdotally, I have seen people stabilize at higher doses, 32 milligrams generally, when people are using high doses of fentanyl. Um, I have also seen patients sometimes be prescribed up to 40 milligrams of buprenorphine, although that's pretty rare. I think it is just because the ceiling effect is probably achieved at the higher buprenorphine dose. Similarly, methadone with fentanyl use, patients do sometimes stabilize at higher methadone doses than they did previously when people were using other types of opioids in the past. But yeah, we are seeing higher doses of methadone stabilization in our current population.
Got it. And my understanding is we reach a ceiling effect specifically for things, so euphoria as well as respiratory depression. But perhaps once you reach whatever milligram dose is needed for that ceiling effect, additional doses still help with withdrawal symptoms and cravings and relieves other entities beyond the things that we tend to focus on. Does that sound about right?
I think that that sounds about right. I think that, yeah.
So some people just need a little bit more to get to continue to kind of help with cravings withdrawal beyond
Yeah, I
that
agree with
ceiling
the
for
cravings, right?
yeah. Okay.
Mhm.
Um, great. And then there was an additional question in the chat from Nancy. So, and this is related to the clinical vignette. The question was, so the increased suggestion of 5 to 10 milligram methadone, Q to 3 to 5 days, doesn't apply for those in acute pain. Could you clarify that for us, Dr.
Oh, I'm
Liu?
sorry. Could you repeat the question? I'm sorry.
Yeah, so in the previous slides, we talked about a stepwise increase in methadone, 5 to 10 milligrams, Q 3 to 5 days. But in this vignette, it doesn't seem to apply because the patient was in acute pain. Um, so pose another way, patients with acute pain, is methadone dosing and escalation different for those who are simply being stabilized in terms of withdrawal? Do we
Okay.
do we
Hopefully
do
I'll
we
answer the question.
escalate the dose
Yeah,
faster in for acute pain patients who are
I see.
also
I see.
suffering from OU?
Yeah. Okay. Okay. I think that I think it's really patient dependent in terms of their opioid tolerance. I would say generally I would start with split dosing, but keep to the
Okay,
similar initial doses of methadone just to
okay.
avoid oversedation with the long acting opioids, dose stacking. I think potentially we could get up to 40 to 60 milligrams in the first day for both acute pain and withdrawal symptoms, but I would caution against titrating more rapidly than that. I think starting with a split dosing, I think would be an important distinction than if you were just treating for opioid withdrawal
Got it. Okay.
in isolation. Hopefully that answers the question.
Yeah. Thank you. And I think Dr. Goulet had her hand up.
No, I was just going to say thank you. Wonderful presentation.
Yeah.